Hereby I open this academic ceremony at Maastricht University. My name is Ton de Goey. I am the Pro-Rector and the Chair of the Degree Committee. And first of all, I would like to welcome Mrs. Haiyan Zeng. And she will defend her academic thesis in public. And the thesis is entitled Optimizing Prophylactic Cranial Irradiation for Patients with Lung Cancer. Welcome all members of the Degree Committee, not only here but also online. And you can see them on that screen and later on the large screen here in front of us. In particular, I would like to welcome the three supervisors sitting here. And the supervisors are Professor Dirk de Ruijser. He is a professor of radiotherapy and in particular respiratory oncology. Dr. Lisa Hendricks, she is pulmonologist at the Maastricht University Medical Center Plus. And Dr. Alberto Traverso, and he is assistant professor in oncology and artificial intelligence, both at the Maastricht University and at the Faculty of Medicine University Vita San Raffaele in Milan, in Italy. I will introduce the 5 opponents later during the ceremony. Welcome all of you here in the aula, and I would like to welcome also all the followers of the live stream. Mrs. Haiyan Zeng, may I invite you to present a summary of your thesis, and I wish you success in the coming hour. The floor is yours.
Yes, thank you very much for Rector.
Please adjust the microphone to your height.
Thank you very much for your nice introduction. Dear Rector, dear committee, dear family, dear friends and colleagues, thank you very much for joining me here today, here or also online. Now I will present my research, optimizing prophylactic cranial irradiation for patients with lung cancer. Lung cancer is very common. It's the leading cause of the cancer-related deaths. In pathology, we can divide it into 2 types, small cell and non-small cell. Non-small cell can be further divided into squamous cell and non-squamous cell. Small cell and non-small cell are very different disease. Small cell is much more aggressive than non-small cell. From here, you can see after years of diagnosis, 2 years later, only 60% of patients are still alive in small cell lung cancer, while for non-small cell, there are 2 times more patients are alive. After 5 years, only 8% of patients are still alive in small cell lung cancer, while for non-small cell, there are 3 times more. For treating lung cancer, we have 3 traditional methods: surgery, radiotherapy, and chemotherapy. Today, our topic mainly focuses on radiotherapy, that is, treating lung cancer with radiation. Lung cancer, even after the treatment, they can have progress. It can spread to other organs, like brain, like liver. Today, we will focus on brain. Brain metastasis is also very common in lung cancer. There are 20% of patients present with brain metastasis at diagnosis. 50% of patients will have brain metastasis during the whole disease course. And for small cell lung cancer, it is even higher, as high as 80%. When patients get brain metastasis, they have lots of sufferings, such as headache, fatigue. They have difficulty in walking. They will feel nausea and vomiting. They also have lots of problems like memory loss. So, brain metastasis should be prevented. But how to do that? Luckily, we have prophylactic cranial irradiation, PCI. It works by irradiating the brain before developing visible brain metastasis. In this way, it can reduce brain metastasis incidence. Of note, PCI, the name is not literally very precise or exactly, because it's not by decreasing the brain metastasis by prevent because it's not like a drug. It cannot prevent brain metastasis, but it can decrease brain metastasis because it can kill the visible, invisible small cells, that is macro metastasis site. So as mentioned earlier, small cell lung cancer have very high possibility to get brain metastasis. Therefore, PCI is very commonly used in small cell lung cancer patients. On one hand, PCI has its advantages. It can decrease brain metastasis. However, on the other hand, it also has some side effects. That is the cons. It can cause some toxicity like memory loss. Ideally, a very good PCI strategy should outweigh the advantages than the disadvantages. Therefore, PCI should be personalized. This is the thesis outline. I will show you what I have done to optimize PCI. In the first part, we try to predict brain metastasis. In the second part, we try to predict memory loss. Now let's take a look at part 1, predict brain metastasis. As mentioned earlier, radiation therapy is a very key treatment method for lung cancer. In this picture, you can see the tumor is irradiated by the radiation. And in this second picture, you can see the tumor is surrounded by the radiation. The third picture shows that patients receive radiotherapy by lying on the couch of the radiation machine. In this chapter, we investigated patients with small cell lung cancer to compare the type of lung radiotherapy because lung radiotherapy has two main methods, once daily and twice daily radiotherapy. Normally, they found that the overall survival and outcome are similar between these two therapies. But surprisingly, some scholars found that the twice daily radiotherapy is associated with a higher possibility for brain metastasis. Therefore, we conducted this study to compare them with a propensity matched score, that is matched exactly for 169 patients in each group. And surprisingly, we confirmed that twice daily radiotherapy are indeed more likely to develop brain metastasis than once daily radiotherapy. It's 1.5 times more likely. Now, we also reviewed the other papers to see what they have found. We identified 61 related papers, and 57 factors were mentioned. Among these 57 factors, we found that 10 factors had qualified data to be further analyzed. Among these 10 factors, we found that younger age and larger tumor are risk factors for brain metastasis. Other factors, such as smoking and radiotherapy dose, are not associated. Now, we also take a further step for patients with non-small cell lung cancer, because this group also has 30% of patients will develop brain metastasis. So we also investigate clinical factors and tumor features on chest CT scans, because the traditional clinical factor models are not very clearly identified the risk prediction. So we need new techniques like radiomics. Now I will show you what is radiomics doing. First, we delineate the tumor separately for lymph node and for the primary lung tumor. After that, we extract the features such as tumor shape, tumor intensity, and tumor texture. And then we analyze the radiomics features with the statistic method and develop brain metastasis models. We found that younger patients and non-squamous cell type are more likely to develop brain metastasis. Features of metastatic lymph nodes are more related to brain metastasis than lung tumor. So this is the lymph node, this is the lung tumor. The lymph node is more prognostic than the lung tumor. Now, we take a further step to part 2, memory loss. We identified 20 related papers and found that high-quality data is lacking. 2 papers had some concerns, and all the others are not very good quality. With this bias, we found that age, higher PCI dose, and twice-daily PCI might be risk factors. So in Chapter 6 and Chapter 7, we investigated a new technique of PCI, that is hippocampal avoidance PCI, because we found that hippocampal area is very small and is not very likely to develop brain metastasis. On the other hand, it's very important for the memory function. Therefore, we think that maybe it's not necessary to irradiate the hippocampal area. So this is a hippocampal avoidance PCI. We don't irradiate the hippocampus. We compare this hippocampal PCI versus the normal PCI, that is the traditional PCI, irradiate the whole brain. With patients with small cell lung cancer, they are from 2 randomized trials, a Dutch trial and a Spanish trial. We found that hippocampal avoidance PCI is safe. Brain tumors possibilities and locations are similar between groups. We also found that hippocampal avoidance PCI does not have a clear benefit over PCI in protecting memories. In Chapter 8, we analyzed risk factors for memory impairment. We used patients with non-small cell lung cancer from the Dutch trial. We found that memory impairment can be classified into 4 types: sustained, reversible, recurring, and alternating. Now I will show you how they are defined. For the sustained, that means impairment is always there at each time point. Reversible means that memory impairment disappeared after some time points. Recurring means that impairment disappeared but then come back again. Alternating means that the cognitive impairment disappeared but come back again and then disappeared and come back again. No, it's always changing. That's alternating. 34% of patients report sustained tap. 26% patients report reversible tap. And 31% of patients reported recurring tap. 9% of patients have alternating impairment. In conclusion, we found that memory loss is dynamic. Memory impairment before irradiation was a risk for subsequent impairment. In summary, optimizing PCI, we found that in part 1, prediction of brain metastasis, twice-daily lung radiotherapy, younger age, and larger tumor are high risks. In part 2, prediction of memory loss, we found that higher PCI dose, higher age, and baseline memory loss are risk factors. Broadly, we also found that memory impairment is dynamic and has 4 types: sustained, reversible, recurring, and alternating. Thank you very much. Now I give the floor back to the prorector.
Thank you very much for your clear summary. The opposition will be opened by the chair of the Thesis Assessment Committee, Professor Frits Franse. He is Professor of Personalized Management of COPD at the Zero Institute in Hoorn in Limburg. Professor Franse.
Thank you very much, Mr. Prorector. Dear candidate, first of all, let me thank you for admitting me to review this very interesting thesis. I'd like to congratulate you with this. Already 6 chapters published, and I noticed you also co-authored a lot of other papers already. So congratulations also to your promoter and your 2 co-promoters. So I'm obviously not an expert in lung cancer or cognitive function. Nevertheless, I found it really interesting to read your thesis, and I started, of course, with chapter 1. And that's where I immediately got some questions I'd like to ask you. You mentioned in your introduction that you chose to use self-reported cognitive function mainly for your thesis. And I read how you measure this self-reported cognitive function. It's mainly a subdomain of a broader health questionnaire, which has been validated for cancer. And you mentioned, well, there are two questions regarding concentration and remembering that relate to cognitive function. You also show some other questionnaires in which a more objective way to assess neurocognition is presented, where also other domains are used. So my question is, and I guess I know your answer, why did you choose this self-reported cognitive function as the main outcome of your thesis? Especially since you also introduced that the objective measurement and the self-reported are not related to each other. In my opinion, the objective measurement would be more important, but I'm happy to hear your thoughts about that.
Highly esteemed opponent, thank you very much for your question. Yes, it is also very important aspect that the cognitive function has two domains. One is self-reported, another is objective. For this one, in this thesis, we mainly focus on self-reported cognitive functioning because for the objective one, we don't have much more new data. Because such as for the ENVOT 11, that is chapter 8, we analyze the cognitive functioning risk factors. We use the self-reported cognitive function because we don't have the objective cognitive functioning. So, yeah.
So what you're saying is it's not that you chose this on purpose, but it's just because you don't have the objective data available. Is that correct?
Indeed.
Yeah. Okay. So then, what would be your opinion then regarding this self-reported cognitive function? Because, as I said, you focus on concentrating and on self-reported remembering. I can imagine that if you just got diagnosed with lung cancer, that a patient starts to worry and starts to be very anxious, and maybe the effect, there's an acute effect of the disease that might have an impact on cognitive function. Is that something that is realistic, or is it just theoretically?
Cognitive functioning has some compoundings, such as anxious or stress. These things are indeed correlated. That's why we need multiple tests. And we also need the objective tests as well. So in this way, we can know a whole picture of the patient's cognitive functioning status.
Okay, thank you. Well, then to continue with that, I'd like to focus on chapter 8, in which you present the results of the ENVOT 11 study, and where you looked, as you nicely presented, also at the, let's say, the 4 types of cognitive impairment, these trajectories over time. And what I noticed is that in your table, you show that at baseline, 22% of the patients had cognitive impairment. And in these 22%, you show these 4 types of, let's say, sustained impairment or alternating or recurring. But as I was wondering, how about the other 78% of patients that did not have cognitive impairment on baseline? Did they also show this variance in cognitive function over time? I would assume so.
Yes, if you have the book at hand, you can see page 328, the figure B. You can see this panel, baseline cognitive impairment. Patients with cognitive impairment and patients without cognitive impairment, they also have 4 types: sustained, reversible, recurring, and alternating. And you can also see the constituent ratio, they are also similar, and the p-value is of no statistical significance.
Okay. So what does that mean for your conclusion then? Because you said also at the conclusion of your presentation that there are 4 types of cognitive impairment and that we need to take these into account. But if if patients without cognitive impairment have the same trajectories, then my conclusion would be that this is just not a stable test, that we cannot use this as an outcome to guide our therapies, for example.
Your proposal is very interesting. I don't think it's really the case, because we will say patients have cognitive impairment even before PCI. That is the point of the baseline cognitive impairment. So cognitive impairment has lots of correlated factors as well, such as mental health, also for the physical status as well, and also some people, they say smoking or hypertension, these things also have relationships. And also for chemotherapy, it's very common for patients with lung cancer. They need chemotherapy, and chemotherapy, they also can cause chemobrain, that is, chemo drugs, they can also have some toxicities for the brain, for the memory, or for the cognitive functioning. So we cannot attribute all the cognitive impairment into PCI. That is the point of the chapter 8. We cannot say if the patient have cognitive impairment because they got PCI.
No, I agree with you, but I mean, you could interpret the results as there are 4 different types of impairments. You could also say, well, this is just a lack of stability of the test.
They also, we can also imagine if we have objective cognitive tests, we can impair that. For this point of view, I can say, take another example as the small cell lung cancer one, that is the Dutch trial. The Dutch trial compare hippocampal avoidance PCI and the normal PCI. In this case, they have objective tests. They also have self-reported tests. So both the objective and the self-reported, they are not significant between groups. So sometimes we do need objective tests as well. But in this case, we do not have. So I hope in the future we can improve this. Always have.
I hope I am allowed one more final question.
If you have a short question, it's okay.
Regarding chapter 5, in which you look at the determinants of cognitive impairment. And what I wrote down is, where is the person behind the tumor? You focus a lot on tumor characteristics and disease characteristics and treatment effects. But I mean, you mentioned already a little bit that smoking and hypertension, but for example, also physical activity or education level, maybe also other comorbidities also have an impact on cognitive function of a person with a lung tumor. So what is your opinion? I did not notice a lot of attention to let's say, to the person in your thesis.
You may give a short answer, please.
I will try to give a short answer. For this chapter, we summarized a lot of factors, and we do not find a very reliable data to show the exact difference between smoking patients and non-smoking patients. That's why we say that we are lacking of high-quality data. So we need future work.
Thank you very much. I'm very happy with your answers, and I'd like to hand over to the pro-rector again.
Thank you.
Thank you very much, Professor Franse. The opposition will be continued by Professor Sara Ramella. She is Professor of Radiation Oncology, in particular thoracic oncology, at the campus Biomedico of the University of Rome in Italy. Professor Ramella.
Thank you. It's a big pleasure for me to be here. And thank you to the pro-rector for this kind introduction. And I'm very happy to see Haiyan, the candidate that is discussing now her thesis. And I would like to follow the discussion that has been immediately done, underline, if it's possible for the candidate, some risk factors for neurocognitive decline. The candidate addressed it very well that the memory is one of the most important decline for the patient, but we well know that also executive function or learning function are something that can change after PCI. And it is true that we don't have enough or high quality data, surely, but probably we can have a discussion on the chapter 5 in particular for the neurocognitive decline and the risk factors that you consider in your patient, which is in front of you in the daily clinical practice. And so which kind of questions, which kind of approach you can recommend?
Highly esteemed opponent, if I understand your question correctly, you want to know whether we have a very good questionnaire or psychological test to assess the patient's cognitive functioning very perfectly. Is that correct?
Yeah, surely is correct, but also in which way which kind of questions you did to your patients to address this kind of problem?
Yeah, that is a really difficult issue because currently we don't have a perfect method to catch the whole picture of the patient's cognitive functioning. That's why we need multiple tests, also self-reported and objectively tested. So yeah, unfortunately, currently we don't have a very perfect tool, but we are working on that.
Yeah, but you say the correct thing. Because you say that we have to test this kind of patients with some reports. And so could you just introduce the risk factors that we can consider? I don't know, you in chapter 5, you address a lot of risk factors that even if they don't have high quality data, we can consider, I don't know, the age for the patients, the ischemic areas, or I don't know, the previous data.
Yes, yeah, currently based on the not perfectly data, we found that age, PCI dose, and regimen timing, these might be associated with patients' risk factors, these are. So personally, if I got a patient that he is 70 years old or 80 years old, I would be very careful for the PCI prescription because they are at higher risk for cognitive impairment. At the same time, I will also try to avoid the high PCI dose. Normally, we just give 25 gray, but not high. 36 gray does only harm and no benefit. And also, yeah, I should avoid sandwiches PCI. That means I should give patients PCI after they finish chemoradiotherapy. And yeah, for the timing, that is also do not give the PCI too early because PCI works by killing the invisible metastasis cells. If I give it too early, it's of no use, and they just killing the normal cells. That makes no sense. That's the lesson we learned from chapter 5.
Yeah. And could I also address another question for you? On the chapter 7, we have you presented very well the hippocampal avoidance prophylactic cranial irradiation technique. Surely is a very important data and controversial data in literature today. And so even if we know that that part of our brain is related to memory, for instance, we don't have enough evidence to recommend it. But probably we will know also that the brain is memory is the hippocampus is not the only related area for the memory because amygdala is also involved. And so we well know that there is a problem of location in the brain of this kind of function because our brain is surely more complex. So could you address the issue of literature, more underline the data that are in which there is controversy. You cited the Spanish, but also the other trial. And could you discuss this theme?
Yes, hippocampal avoidance PCI is a very hot topic because we always try to maximize the advantages and the benefits and try to avoid the harms. So hippocampal avoidance PCI works, or we just say we hope it will work. But in this chapter, we do not find a very clear benefit for the self-reported cognitive functioning. And for the objective cognitive functioning, the Spanish one you also mentioned, they say, yes, indeed, hippocampal avoidance PCI can protect the memory function. But on the other hand, at the same time, the Dutch trial shows the opposite result. That means the objective cognitive functioning is not significantly different between two arms. So unfortunately, currently for the objective cognitive functioning, we cannot have a very robust conclusion. But fortunately, we have an ongoing trial. They are also investigating the hippocampal avoidance PCI and normal PCI. The conclusion and results might come very soon because they already finished the patient's recruitment. And we are all looking forward to the result. In that case, we will have more objective data to draw a more reliable conclusion.
Yes, surely. And it's true that also what is very not uniform from the literature data is the timing in which we administer the questionnaires to the patients. And so probably there is a difference between 4 months, 6 months, and so we have no homogeneous data by which we can have a conclusion on this. And probably, as you say, for the future, the new insight in this with the new trial can give us this kind of ideas. And so I'm very impressed for your work during this thesis, and I have just a little few questions on the if is it possible, I don't know, Prorector, we have just 1 minute more.
No, I think we have to move on to the next opponent, yes.
Thank you.
Thank you very much for your questions. The next opponent is Professor Corinne Ververe-Vin. She is Professor of Thoracic Radiation Oncology at the University of Manchester in the United Kingdom, and she is affiliated with the Christie NHS Foundation Trust. Professor Ververe-Vin.
Thank you very much, Mr. Prorector, and dear candidates. So very much enjoyed reading your thesis. Very, very interesting and a huge body of work. So congratulations on that. And I like very much your quote about the moral compass of doctors. So that was very enlightening. So I'm going to start my first question on twice daily radiotherapy versus once daily radiotherapy and the risk of brain metastasis, which in your chapter 2, your results somewhat contradict what we found in our CONVERT trial. So you found a higher risk of brain metastasis in patients having twice daily radiotherapy. So I'd like to ask you whether there are some confounders that may have not been taken into account in your study. Some of them may be known, and then some, of course, may be unknown, which is more complex. So in such case, are you aware of methodologies that could help you make a causal relationship between the occurrence of brain metastasis and risk factors?
Esteemed opponent, thank you very much for your question. Yes, for chapter 2, it is very interesting because the results are different from the prospective CONVERT trial. In the prospective CONVERT trial, it says that the twice-daily radiotherapy and the once-daily radiotherapy had similar possibilities to develop a brain metastasis. While in our chapter 2, we found the opposite conclusion that twice-daily patients are more likely to have brain metastasis. The very big difference is that chapter 2, this is a multi-center retrospective study, while for the CONVERT trial, it is a prospective trial. For the Chinese trial, we have multiple centers. We try to control the confounders by using the propensity score matching. The propensity score matching, it can help to control some confounders. That is, all the confounders we can observe. That's why we match the 16 variables. We try to identify all the confounders as much as possible. But as you mentioned as well, there are some unknown factors as well. It also happens in the clinical trials, of course, because for the clinical trials, we are randomized patients from group 1 to group 2, and sometimes we do the stratifications such as smoking status or staging status. We try to avoid this as well, but that is the inherent limitation of the retrospective studies. We have done whatever we can to minimize the bias. And in the future study, I also think because the Chinese population, they are from the Asia origin, and the CONVERT trial study, they are from the European. So maybe the patient's ethnicities are also play a role there. So just a case like the EGFR mutation status in the Chinese or Asia population, the possibility is much higher than the European or Western patients. So it can also be a confounder.
Sorry to interrupt, but my question is about, so you've done propensity matching, which is great, but are you aware of other methodologies that can be used to take into account, to make these causal relationships between risk factor and an event such as brain metastasis?
Do you mean use these patients' data to identify risk factors for brain metastasis?
To make a causal relationship. There's a very specific methodology that is a new methodology that's been used in recent years to establish that link, so a causal relationship.
Sorry, I don't understand.
No, that's okay. That's okay. So that's what I'm after was causal inference, which is clearly a methodology that tries to make you sort of create that link between an event.
You mean the mechanism? Why do you find that twice daily is more likely to have brain metastasis? Is that what you want to ask?
Yes.
Yeah. So for the twice daily, we think it's mainly because of the radiobiology. Because twice daily patients, they get radiation 2 times a day. And we know radiation has another side effect that they also damage or injure the normal tissues. So for twice daily, they don't have enough time to repair the normal tissues. While for once daily radiotherapy, they have 24 hours to repair the damage or injury. So we say the brain metastasis cells, they are spread from the lung to the brain. The brain cell, the cancer have to transmit the blood-brain barrier to get into the brain. You can just say it's like a door. The cancer wants to get into another room, he has to close the door. If the door is broken, then the cancer can penetrate and close the door very easily. While for the very well-functioned door, then it takes much more efforts to close the door. So that's why the twice-daily radiotherapy patients show the more possibility to get brain metastasis.
the mechanism, but what I was after is, how you can make a better relationship between, is twice daily radiotherapy really the cause, and one of the risk factor of patients developing more brain metastasis. But anyway, we'll move on to the next question. So you have a very nice chapter 4 on radiomix to predict the risk of brain metastasis in stage 3 non-small cell lung cancer. But of course, we know that there are limitations to radiomix analysis. And could you just summarize in a few words, because I know it's a big field, what you think are the main limitations of these studies with radiomix, and what are the clinical implications of your finding in chapter 4? So thinking about applying this to the clinic, what do you think is the way forward?
For this chapter, we investigated models for the brain metastasis in patients with non-small cell lung cancer. And for non-small cell lung cancer, there is a very important aspect, that is mutation. Like EGFR mutation, ORC mutation. For this chapter, we do not analyze this because we did not correct this data. But there are other people, they have done the related job. They found that radiomics have the significance to distinguish mutation status, like ORC, whether the patients have ORC mutation or no mutations, like EGFR. Other colleagues already have done the related job. So, in this chapter, we didn't focus on this.
Sorry. Can I clarify? What I'm after is, what are the general limitations of radiomic analysis? So if you consider radiomic, as a prognostic factor, for example, I mean, we know from the literature that there are many limitations. And can you name a few of them?
Radiomics
you may
limitation.
give a short answer, please.
Such as the repetition and regeneration, and you just to repeat the results to more populations. That is also the problems, and also like a black box, it also is very widely and commonly mentioned. These are limitations for radiomics. Is that clear?
Okay, and then, you mentioned a number of them, but if we now think about the findings of your chapter 4 and what are the implications in terms of clinical practice? So you've identified some features, including radiomic features, to predict the risk of brain metastasis. How would you take that forward?
I have to interrupt
if you want?
We have to move on to the next opponent. We have to move on to the next opponent. Disappeared. The next opponent is Dr. Monique Hoxtenbach. She is pulmonologist with special interest in lung oncology at the Maastricht University Medical Center. Dr. Hoxtenbach.
Dear candidates, congrats with your impressive thesis, and also congrats to your promoter team. And finally, you can realize your dream, because you stated, you told it to me, that was your dream to be here. I would like to ask you some questions about chapter 5. I will start with chapter 5, and also how you also mentioned PCI leads to neuro and cognitive impairment. And you presented your work with the seated soul radiomics model. And actually, I would ask you, so would it be not in future, that we have a radiomics prediction model, of course, both primary tumor aspects, but also pre-metastatic brain features? Is that something what you can look for in future? So you have some clinical signs, but if you want to go straight to the normal brain and with radiomics, should there be a possibility in future? And to prepare for example, PCI.
Esteemed opponent, thank you very much for your question. Yes, we do think about this as well. For normal brain MRI or CT, we try to identify some clue to predict brain metastasis and try to provide more information for PCI. And the project is ongoing, and we already have collected the data. I hope the publication will come soon. And I will also update you as well.
What can be the pitfalls when you use normal tissue?
Pitfalls of the normal tissue?
In predicting?
Normal tissue pitfalls to predict. Okay, we just have some hypotheses. Why we say the brain CT or brain MRI might have the possibility to predict brain MRI, brain metastasis, because we are just mentioned as well. The cancer cells, they spread from lung to brain. They need some time. So there is a theory called environment and the fruit, and the soil and the seed. That means the cancer cell of the lung is the seed, and the brain is the soil. That is the environment for the cancer to grow up, to become a metastasis set. So we say they take some time. We cannot see it clearly on the images with our gross eyes, but for the radiomics features, they can analyze more in depth. So maybe there are already some change. Humans I cannot find, but the radiomics can show some difference. That's the mechanism or hypothesis we do these studies. So for the pitfalls normal tissue, it's not really a normal tissue. It's already changed. The macroenvironment already changed, and it's not the same as normal tissue already. That's why we think it can work.
Thank you for this answer. Then I would ask you some question about chapter 6, the hippocampal avoidance whole brain radiation. It's not the standard of care, I suggest, because you find out that it's not avoids the complaints. So, but there's still more investigation with memantine. The product, and phase 3 thought, well, they were very proud because they found out that memantine in combination with radiation will be the new case to do radiation combination with. Is that the case what you can present it also as a new way of radiation and with other, find out with other salts, whatever? What I mean to say is, do you understand this and would you prefer it?
Yes, memantine is a very, also very hot topic. They investigated for the patients with the brain as well, for the whole brain radiotherapy. They try to add memantine to see whether the patients have less problem with the cognitive impairment. And for, we already have positive results on this topic. But for small cell lung cancer, for the hippocampal avoidance PCI, they are prevented the brain metastasis before they really develop brain metastasis. So it's a new topic. We also mentioned that in chapter 9 for the future work. We think we can try that as well to see. In that way, we can hopefully see a positive result that patients with the hippocampal avoidance PCI and together with the memantine have more benefits than patients with PCI together with memantine. So in this way, maybe we can hopefully find the same results as the brain metastasis patients, like the USA trials.
So there will be in future. No.
Yeah. Look into the future.
Thank you for your answers. I give my
Thank you.
to the prorector.
Thank you, Dr. Hoxtenbach. The next opponent and last opponent is Dr. Leonard Weng. He is Assistant Professor of Radiomics and Prognostic Modeling at Maastricht University and affiliated with Maastro. Dr. Weng.
Thank you, Prorector and dear candidate. Congratulations again on a very impressive thesis. Congratulations to your promotion team. I'm the only non-physician on the panel, so I think you know that I'm going to ask you about Chapter 4. Right? I want to understand and discuss in a good way with you some of the implications of your results in Chapter 4. So I find it very impressive that you have included 4 institutions in the development of your model in Chapter 4. My question to you is, have you noticed any systematic differences between these 4 institutions? And perhaps you could comment on how you might check what might be the consequence on your models if there are differences in these 4 hospitals.
Esteemed opponent, thank you very much for your question. If I understand your questions correctly, you want to know the patient's data. We have patients from 4 hospitals. You want to see whether there are some difference between these 4 hospitals.
Well, one source of differences could be the patient mix in each of the hospitals, but do you think there are other differences also that can happen between the 4 hospitals?
Actually, these all the 4, except one center from Italy, all the other hospitals, they are referring the patients to Maastricht. So they are all Dutch hospitals. They are mostly from Maastricht or Limburg. So we didn't investigate that, but I presume there are no very significant difference between these patients.
Okay, so they use all the same scanners and they use all the same imaging settings?
So for the CT, only the Italian one, they have their own CT scans. For all these other hospitals, they have the CT scan transferred to Maastricht, but we use the planning CT. Planning CT, that is, patients take a CT before they get the radiation therapy. So all the patients have the same CT scanners because they do that in Maastricht.
Right. So effectively, there's 2 groups, right? The Dutch group and the other group. Okay.
Italian group.
So this is still a very impressive tripod type 2B study, huh? So well done. Now, the authors of tripod also suggest that there is one way we can check for some of these differences, right? They would suggest that maybe you could train the model on the Dutch patients and validate it on the Italian ones, and then repeat it, but in the opposite direction. Do you see any advantages or disadvantages with trying that? Because at the moment you put all the patients together in one, right? What about this is what I suggested, right? Fit the model in the Netherlands, try it in Italy, and then vice versa, see what happens. What do you think?
Ideally, that would be better. Unfortunately, we cannot have the Italian images at hand. Because of logistic reasons, they cannot transfer the images to us in time. So we cannot do it, not because we don't want to do it.
Right, okay.
Yeah.
So it's some sort of a data blockage problem. Okay, so let's move on to something else that I thought was really interesting in your chapter 4. Huh? Mm-hmm. If you look at page 190 and 191, perhaps you could help me understand the relationship between your figure 3, I believe it is, and your table 3. Yeah. Especially the decision analysis curve. You tell me that your model provides a net benefit for threshold probability smaller than 0.3. And if I look at the figure about the decision analysis curve on page 190, could you walk me through how you understood that, how you interpreted that as a better for probability thresholds less than 0.3?
So do you mean, why do I say the GTVN radiomics model is the best one?
No, you tell me that there is a net benefit for threshold probabilities less than 0.3, and I'm trying to understand where did 0.3 come from.
Sorry, could you please repeat it?
Okay, you tell me that there is a net benefit if your model predicts a threshold probability less than 0.3. It's on page 190, yeah? Yeah. I'm trying to understand, where did you get this number 0.3?
This is visually estimated. You see the image 0.2 and 0.4, and yeah, you see the cross point. You see all the figures, all the curves. The green one, the yellow one, the purple one, you see they are almost crossed at least 10 points. That is 0.3.
Okay. So, all right. Let's suppose I accept that 0.3 is the magic threshold number. As a clinician, seeing a patient in the room, and let's suppose you are using your own model, if your model outputs a number that the probability of 2-year brain metastasis is 0.31, so higher than 0.3, but 0.31, what would you do? And before you answer, if the model then also prints out 0.29, what would you do as a clinician?
Yeah, if I got this situation, I would do both and compare the result.
Oh, you would do both as in?
Yeah, currently from the 0.3 point, we say the green one is the best. That is GTV and radiomics is the best. But then when the situation you mentioned, if it happens, I will just compare the other models as well.
Okay.
And then we will try to further test it.
Right. But your model tells you the risk of the patient getting brain metastasis, right? So would you treat them with PCI? Would you not treat on the basis of the output of your model?
For these patients, they are non-small cell lung cancer. For non-small cell lung cancer, PCI is still not the standard of care.
Right.
So I would not do that in clinical practice.
Okay.
But I can do that in clinical trials.
Sure. Okay, so clearly we would need some trials, and because what I was trying to get to you is whether you have a feeling for the uncertainty in your model. Do you have a feeling for the level of uncertainty in your prediction models in chapter 4?
A feeling for the uncertainty mainly focus on the radiomics features. Because there are so many radiomics features, 861. Currently, we got 5 positive features in each radiomics model. But as I mentioned earlier as well, radiomics has some limitations or shortcomings. There are some black box. What's the exact meaning of these 5 features? If I redo the test, maybe I would get another 5 features. That is also a possibility. So that's a feeling about uncertainty. That's why we need more studies like machine learning or deep learning or AI. We need a big data to draw a more confident conclusion.
Sure. And we do see that, right? We do see that every time we select the features, we might get a different one. But that leads me to this interesting question I have for you then, in terms of the features that you pick. You made 861. You only use 5, so that seems like a very low return on investment. But my question to you is, these 5 features that you have picked, one of your co-authors is an expert in repeatability and reproducibility. Do these features that you pick in the model, do you know if they are repeatable and reproducible?
To be honest, we had a midterm analysis. We submitted this abstract to a congress. And in that abstract, we use almost a different methods to training and extracting the features. The main conclusion is that that GTVN radiomics feature is better than the GTVP radiomics feature. But the detailed radiomics features, if you look in detail, is a little bit different. They may lie in the same category because so we have 861 features. They can categorize into six subtypes. So you can see within the same types, they are the positive features, but in a detailed names, they can be varied a little bit. So from this abstract to this whole manuscript, you can compare the difference.
So features that are predictive are not necessarily repeatable, and features that are repeatable may not be predictive, right? What do you think?
Mrs. Haiyan Zeng, As you have seen and heard, the time for defending your thesis has passed. The committee will now withdraw to discuss the quality of your thesis and in particular the quality of your defense. And please await our return.
Thank you.
All right, please.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes.
Long road to the south side, 7 miles in my rearview mirror. I know what it felt like. My goal's only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and die. On the line, I know you know that I can't read your mind. Years can't fly by now, don't waste all your time. Cause I'll go the extra mile. Long road to the south side, 7 miles in my rearview mirror. I know what it felt like. My goal's only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and die. On the dash, got my laces tied. Long road, I don't waste no time. Break rules because fate decides. With the team and we chase the light. I make a move, fall down, shake it off. I hate to lose, bad branch, break it off. No room for negativity, praise and love. Prepare for deep part cause we're taking off. Take the mileage, traveling so far from home. Gathering knowledge, other connections. I put the time in to get everything I ever hoped for. It's a challenge and we all in. It's a better future that we go for. And even though these nights seem long, I know that I am never on my own. Know you've won the battle once you've grown. South side, 7 miles in my rearview mirror. I know what it felt like. My goal's only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and die. Long road to the south side, 7 miles in my rearview mirror. I know what it felt like. My goal's only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and die. What's on the line? I know you know that I can't read your mind. Years can't fly by now, don't waste all your time. Cause I'll go the extra mile.
Mrs. Haiyan Zeng. The committee here present, not only here but also online, has assessed the quality of your thesis and the quality of your defense. And in view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. And Professor de Ruijser is authorized to confer upon you this academic distinction in accordance with Dutch university custom and law. I invite now your supervisor to take the floor. Professor de Ruijser.
Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
Yes, I promise.
By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Haiyan Zeng, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, I will now present you with the degree certificate signed by the rector, the secretary, and the other members of the committee, and affix it with the official seal of the university.
Thank you.
And the laudatio will be given by Lisa Hendricks.
Dear Haiyan, dear Dr. Zeng, you did it. You obtained your PhD, and what a journey it was. You really jumped into deep water with approaching Dirk and me for a potential PhD project in the Netherlands, I think approximately 5 years ago, without knowing us, without knowing Maastricht, Maastricht UMC, the Netherlands in general, and without speaking any word of Dutch. And already during our teleconferences to discuss potential projects, you were really motivated, and you managed to write in a very short time a research proposal for which you were awarded a very competitive CSC grant. So I think you already had a flying start. And less than 4 years ago, you came to the Netherlands and you continued with that flying start with a systematic review. And I think I've never seen anyone doing a systematic review with the speed you did, and I had to check all the things you selected, so lots of pressure on me. But then I think you really had some setbacks with COVID, lots of challenges for you, not only on a personal level, because of course going back to China was absolutely forbidden, but also regarding research, as there were travel restrictions and difficulties getting data, images, your radiomics research, all pulmonologists, medical oncologists, which were you collaborating with, were busy treating COVID, and you didn't get your data. However, despite these restrictions, you built an international research network ranging from the Netherlands, Italy, UK, Korea, and China, and involving also multiple specialties. And all these international key opinion leaders now know you and work together with you. So I think this is very impressive for a PhD candidate. And your statistical knowledge is excellent. And for everyone here in the audience, if you really want to have a perfect data set for your research, give the data set to Haiyan. She's very, very thorough in doing research, and impressively you spotted mistakes in several already checked data sets by professional people, and even renowned statisticians stated, if Haiyan says so, it is so. Moreover, your work has been recognized and awarded, not only because of your publications, and you had many, but you also had several oral presentations at international conferences. You won a René Vogel's Travel Award, as well as a Chinese award for a research proposal you still need to do. And I think everyone here already knows you are a very, very hard worker. And what maybe not everyone knows is that you published multiple other papers, including another systematic review, and I had to check again, besides your thesis. And this is not everything. At Maastricht, you worked also completely outside of your thesis, also on cardiac substructures research. And I heard a colleague referring to you as the Michelangelo of radiation oncology. You are even more precise in contouring than Michelangelo was in painting. And I think that says something. To finish, you are not only a very good and motivated researcher, but you are a very social person, really trying to improve knowledge and conditions for other PhDs, as you were a very active PhD representative for GROW. Moreover, I yesterday heard you obtained a yellow band in karate, and I think you're a very fast learner. We made clear the last 4 years, and I think within a couple of years we need to watch out having discussions with you, but probably you will have a black belt by then. Haiyan, I did this presentation in English because all your family and friends need to hear what you achieved. But for you personally, I could have done this in Dutch, as this is also something you mastered in a relatively short time period you were in the Netherlands. Haiyan, I wish you all the best in your future career with your new job as a clinician researcher in the renowned No. 3 West China Hospital. And for those that are not in the medical field, this part of China is also very famous for pandas, so I expect some pictures. I hope we can keep on collaborating in the future, and again, congratulations with this impressive milestone.
Thank you very much.
Esteemed Dr. Zeng, dear Haiyan, it's my great pleasure to congratulate you with your doctorate, and I congratulate you also on behalf of Maastricht University and the Board of Deans of the university. And I would like to share some impressions of the committee with you. We have enjoyed a very clear, comprehensive and informative presentation, the summary of your thesis. I think and I hope also that for lay people it is also very understandable what you did. Your thesis is a good thesis, well written, and it represents an impressive piece of work. You are a hard worker, I heard. And we have seen a thesis which addresses an important issue. It's rather complete, has very many findings, and special that it combines in a very good way the technical aspects and clinical aspects. And I think that's very worthwhile to see that. And with your defense, I think that most questions you have very well answered. We would have discussed a little bit more on a certain amount of subjects, but we also know that you are already thinking maybe of going back, and you are very relaxed, but we are very satisfied with your answers. I congratulate not only you, but also your 3 supervisors, Professor Dirk de Ruyscher, Dr. Lisa Hendricks, and Dr. Alberto Traverso. Congratulations with the results in the form of an excellent thesis and an excellent defense. I would like to include in my congratulations also your parents and your family. And I hope that they are looking in the live stream and have seen you performing today. And I also include in my congratulations, I think, a number of colleagues that are present here in the aula, but also all other people that have contributed to your studies. And I wish you a very happy personal life and also a progressive professional life. So I hope, and I'm quite sure that you will succeed in that. I would like to thank all the members of the degree committee and of the thesis assessment committee, not only here but also present online, and in particular I would like to thank the external members of the committee, and I would like to invite the 3 online opponents to congratulate the young doctor. And I would like to start with Professor Fransen. Would you like to start?
Yes, thank you very much. So Haiyan, congratulations on your achievement. And yeah, you made it really easy for me to chair the assessment committee because your thesis was excellent and also the way you performed today. So I was happy to meet you yesterday in our department, and I wish you a very nice day and good luck with your career.
Best of friends.
And Haiyan, it was a pleasure to be able to participate, even if only partially, in this path that you have led in the field of research. I'm sure that the scientific work will be able to benefit from your contribution, and I hope to have the opportunity to collaborate with you in future. Congratulations.
Very much, Sarah.
Hi, and congratulations on an absolutely amazing body of work. I mean, it's very, very clear that you've worked extremely hard, very important findings that have contributed to the literature on this field. And I would echo what Sarah said. I hope we keep in touch, and I hope we have opportunities to work together on collaborative projects in the future. All the best to you.
Thank you so much, Corinne.
Before I close this academic ceremony, I would like to thank the 3 online opponents for their input and also for their nice words and their congratulations. And after the closing of this ceremony, I would like to invite the audience here in the aula to go to the rafter. There is the reception, and we will stay here to make a picture with the three opponents still on the screen behind you. And then we are making a second picture in the hall, on the stairs in the hall. Hereby I close this academic ceremony.
Thank you. Thank you so much.
I will close it because if something goes wrong,
Thank you so much, Director. Okay.
maybe do you want to show it again, or do you want to be very careful and close it?
Then let's
Open it.
Can we make a photo of it?
Yeah.